Welcome to the class. Today's discussion is about sexual and reproductive health module. We are going to cover the FSRH guidelines from here onwards. And first is about the barrier contraceptives. Okay, today's session is about barrier methods of contraception and STI prevention. It is a guideline from Clinical Effectiveness Unit published in August 2012. It is updated in October 2015. We begin with our code, that is master MRCOG with concept oriented clarity. In the beginning only, I would like to tell that this SRH module is going to be very important because it has got many SBAs and EMQs. You might get 3 to 4 EMQs from this particular topic. And you know what is the importance of EMQ, because your whole pass or failure depends upon the number of EMQs which you are going to attempt correctly. Okay, so if you master this particular module, you are likely to score quite good in your EMQs. Okay, so we begin with our session on barrier contraceptives. So barrier methods generally include male condoms, female condoms, diaphragm, cervical cap, and DAMs. Okay, in male condoms, what we have is a latex, non-latex, and deproteinized latex varieties. In female condoms, we have nitrile and latex. Okay, for diaphragms, we have latex and silicone. Cervical cap is made up of silicone, and DAMs will be again latex and non-latex. The diaphragm or cervical, from here onwards the SBA questions will start. Okay, so the diaphragm or cervical cap must be left in situ for at least 6 hours after the last episode of intercourse. Okay, so sperm in the lower reproductive tract are unlikely to be alive after 6 hours. So here is a SBA. The diaphragm and cervical cap, for how many hours should be left in situ? It is, the answer is 6 hours. Okay, so remember this particular line: the diaphragm or cervical cap must be left in situ for at least 6 hours after the last episode of intercourse, because after that the sperms are unlikely to be alive. Latex diaphragms can remain in situ for maximum of 30 hours, and silicone cervical cap can remain in situ up to 48 hours. So this is the maximum time for which these can be kept. Like a latex diaphragm can be kept a maximum for 30 hours, and the silicone cervical cap can remain in situ for 48 hours. Okay, while the condoms are use and throw, so they are not to be kept for a longer time. So the diaphragm or cervical cap can be inserted with spermicide at any time before the intercourse. However, the next couple of lines are important. Spermicide should be reapplied if the sex is to take place and the diaphragm or cap is in situ for more than 3 hours, or if the sex is repeated with the method in place. So this is very important. So the diaphragm and cap, so it's always preferable to use along with the spermicide and insert before the sexual intercourse. Okay, suppose if it is in place, so in for more than 3 hours, in that particular case, spermicide should be reapplied. So if it is already in place, the diaphragm or the cervical cap, if it is already in place, in that particular case, spermicide should be reapplied. So spermicide should be reapplied if the sex is to take place and the diaphragm or cap has been in situ for more than 3 hours, or if the sex is repeated with the method in place. Okay, so a diaphragm or cervical cap should not be removed until 6 hours after the last episode of intercourse. So these couple of questions about the number of hours is going to be very important. So how many hours it should be kept in place? It should be in place for 6 hours. Second, when the spermicide needs reapplication, spermicide needs reapplication if the diaphragm or cap is in place for more than 3 hours, or the sex is repeated with the method in place. Okay, so the method is already in place, but there is a repeat sexual intercourse, then spermicides are to be reapplied. And these are the maximum number of hours for which these barrier contraceptives can be kept in place. So the wordings of the question are going to be very important, what exactly has been asked. Okay, now, these are the percentage of women experiencing unintended pregnancy within the first year of use of barrier contraceptive methods. So here it is the failure rate which they have mentioned about these barrier contraceptives, about the spermicides, female condoms, male condoms, and diaphragm. Okay, so these are also either SBA or EMQs. Okay, so not only the barrier contraceptives, but other contraceptives also failure rate, the typical as well as perfect, we should know. Any idea about the perfect use and the typical use? Dr. Sinchana, can you tell me about the difference between the perfect use and the typical use?
Uh, the typical use is how normally couples use them, and perfect use is how they should use them.
Yeah, correct. See, perfect use is under ideal conditions. Whatever the instructions, the guidelines are given. Generally, whatever the this particular thing come, generally with some instructions, information leaflet is there. So, like what you have any gadgets. So, if all the instructions are followed, that is under ideal conditions. If it is used, then what is going to be the failure rate? But what happens? The practically it doesn't happen. Not all instructions will be followed. Say, for example, about the timing of the oral contraceptives. Okay, so there may be variation in that by the patient or by the couple. So that will lead to the typical use. Okay, so the failure rate will increase with the typical use, but under ideal condition, what is the failure rate? So please look into the question what they have asked, whether perfect with perfect use they have mentioned or with the typical use they have mentioned. Now let's see about the spermicides. So very high. Even with a perfect use, it is 18, and with typical use, it is 28. For female condom, it is 5 and 21 is a with typical use. Then male condoms, it is 2 under ideal conditions or perfect use, and it is 18 for typical use. And diaphragms are 6 and 12. 6 for perfect use and 12 for 6 for perfect use and 12 for typical use. Okay, so this have you understood this? The perfect and the typical use, and these are the numbers which you are supposed to remember. Okay, so we'll go ahead.
Yes.
So male condoms are 98% effective. 98% effective means failure rate is 2%. Now this 2% is under ideal conditions, that is when used perfectly. Okay, and if typical, what is the failure rate we have just seen? For condom, it is 18. Okay, go to the previous slide. See, 2 and 18. Okay, these things, these figures, numericals, you should remember. Then here, for 95% effective, female condoms are 95% effective. That means failure rate will be 5%. Okay, so it is 5% with perfect and 21% with typical use. Okay, you got it. So you'll remember this. 98% and 95%, remember. Okay, 98% and 95% is the effectiveness. So 2% and 5% with typical use, with the perfect use, and 18% and 21% with a typical use failure rate. Is it clear?
Yes, sir.
Yeah,
Yes.
okay. So pregnancy rates are similar for both latex and non-latex condoms.
Yes.
When used, yeah, when used consistently, correctly with spermicide, diaphragms and cervical caps are estimated to be between 92 to 96% effective in preventing the pregnancy. Okay, so the consistent and correct use of spermicide, diaphragms, cervical cap is important. Okay, now let's see here. Rarely they can ask you, but do remember these rates. Okay, the risk of HIV transmission following sexual intercourse or sexual exposure to a known HIV positive individual. Okay, so what is the risk of HIV transmission following sexual exposure to a known HIV positive individual? So it depends upon the what type of intercourse it is, whether it is receptive or whether it is insertive, whether it is anal or vaginal or oral. Okay, so we have all 6 options, whether it is receptive or insertive, and whether it is anal, vaginal, or oral. Okay, so depending upon the risk of transmission, so estimated median risk of HIV transmission per exposure they have given. So receptive anal intercourse has got a maximum, that is 1.111% risk. So receptive anal intercourse has got the highest risk of HIV transmission, that is 1.11%. Then insertive anal intercourse 0.06%. Receptive vaginal 0.1% only. Okay. So unlikely rest of the things they can ask you, but I'll just cover insertive vaginal intercourse 0.082, receptive oral, that is fellatio 0.02%, and insertive oral, that is receiving fellatio, is 0%. Okay, so 0% with the insertive orals, that is receiving fellatio, but the highest is with a receptive anal intercourse, that is 1.11%. Now about the STIs. Now what happens to the chlamydia trachomatis? So the chlamydia trachomatis can be transmitted in vaginal or seminal fluids through vaginal, anal or oral intercourse. Prevalence of infection in partners of those diagnosed with chlamydia is up to 75%. So this is also one of the SBA. If a person is found to be positive with chlamydia, what is the risk of partner being positive? Okay, so the prevalence of infection in partners of those diagnosed with chlamydia is up to 75%. Okay, so this particular figure also you should remember. The consistent and correct use of male or female condoms is recommended to reduce the risk of chlamydia transmission. For women living with HIV or at high risk of HIV infection, the use of either a diaphragm or cervical cap is UK MEC3. Okay, so because they will be in place for minimum 6 hours. Okay, so the risk of infection will be high. For women living with HIV or at risk of HIV, use of a diaphragm. So if the person is having this infection, HIV infection, so diaphragm and cervical cap will be UK MEC3. Okay, so though we say that the barrier contraceptives are protective, the condoms will be better, but when it will come to the cervical cap or diaphragm for these patients, HIV positive patients, it is going to be UKMEC category 3. Okay, women with sensitivity to latex should avoid the use of latex barrier contraceptives and may use silicone diaphragm, cervical cap, non-latex male or female condoms, or deproteinized latex male condoms. Okay, so if there is a sensitivity to latex proteins, the use of latex barrier contraceptives for by these women are to be avoided. Okay, they can use other like a silicone diaphragm or cervical cap, non-latex male or female condoms, etc. And for women with history of toxic shock syndrome, the use of diaphragm, cervical cap or contraceptive sponge is UKMEC3 because they will be in situ for 6 hours. Okay, so that will further aggravate the possibility of infection. So if there is a history of toxic shock syndrome, then all those methods where these barrier contraceptives are in place for some time, they are UKMEC3. Okay, so they will ask you about these categories. Okay, so women with history of TSS may use male or female condoms. So if there is a history of toxic shock syndrome, male or female condoms can be used. However, the diaphragms, the cap, contraceptive sponge will be UKMEC3. Okay, now let's see about summary of UKMEC as they apply to different barrier methods. Okay, now this is a complicated valvular and congenital heart disease such as with pulmonary hypertension, atrial fibrillation, history of subacute bacterial endocarditis. Now here they have mentioned about the condoms and the diaphragm or caps they have compared, and they have given here various situations. So for complicated valvular and congenital heart disease, see the condoms are mainly category 1 except when there is a sensitivity to latex proteins. Okay, remember about the condoms, when there is a sensitivity to latex proteins or applies to the latex condoms and diaphragms only, the UKMEC is 3. Okay, so in barrier you don't see any UKMEC 4, here it is UKMEC 3 if it is a latex sensitivity. Now only issues are with the diaphragms and caps, so it will not have one under these particular indications. Okay, so complicated valvular and congenital heart disease condoms are 1 UKMEC category, while diaphragms and caps are 2. While in these 4 situations, that is if the patient is high risk of HIV infected or not using ART or using antiretrovirals, the diaphragms are caps are UKMEC3. If the patient is a known case of AIDS using antiretrovirals, again it is MEC UKMEC3. Okay, if there is a history of toxic shock syndrome, again diaphragms or cap are UKMEC3. while condoms are UKMSC 1 in all these situations, including the congenital heart disease or complicated valvular heart disease, the high risk of HIV, HIV infection, AIDS, all these cases, these condoms are UKMSC 1, including the toxic shock syndrome. Okay, now if there is a Paris woman, again condoms are 1, and diaphragms are here parity. Paris woman, it is UKMEC 2. Remember, Paris woman, the diaphragms and caps will be UKMEC 2, while condoms are 1. And urinary tract infection, again, this condoms are UKMEC 1, while diaphragms are category 2, UKMEC category 2. And sensitivity to latex, both will be UKMEC 3. So is it clear about the UKMEC?
Yes, sir.
Yeah. Okay. So that finishes topic about barrier contraceptive. Thank you.